Hello everyone. In this video we'll be discussing about basics of RCT, that is root canal treatment. So when is RCT done? So when a patient comes to us with a history of pain, with the complaint of pain, we have to decide whether we have to go for conventional cavity preparation, IPC, DPC or RCT. So these are the various treatment modalities which differ according to the clinical situation. We have to assess the situation and then decide what we have to do. For that, we should know signs and symptoms of various pulpal and periapical diseases, which will help us to formulate the treatment plan. So, once we have decided that this tooth will go for RCT, we cannot directly jump into the excess cavity preparation. Before starting the procedure of RCT, we should make sure that we have the basic knowledge of the root canals, that is, how many canals are present in which tooth, and so on. So, what all you should know before initiating an RCT on a tooth? I'll be discussing about that, and then in the end, we'll be discussing about the steps of root canal treatment in brief. The various treatment modalities depend on if the pulp is exposed or it is not exposed. So, if the pulp has not been exposed, we have two options. Either we can go for conventional cavity preparation and then filling, and then or we can go for IPC. And this depends upon the extent of the carious lesion. If the carious lesion is shallow, we can make the conventional cavity and then restore the tooth. However, if the lesion is deep, if the carious lesion is deep and almost approaching pulp, see, this is enamel, this is dentine, and this is pulp. The lesion is almost, this is about to approach the pulp. In these cases, what do? We go for IPC, that is indirect pulp capping. In this procedure, what do? We remove the superficial carious lesion and then we retain a part of the deep dentine that is affected, or hard dentine, followed by the placement of a suitable medicament which will promote pulp healing or recovery. If the pulp is exposed, that is, in cases of exposure, we have two treatment options, that is direct pulp capping or RCT. So when is direct pulp capping done? In this, the size of the exposure will be small, that is, it will be a pinpoint exposure, okay? Or the pulp is, if there is a mechanical exposure, that is, the pulp is vital, so we can perform direct pulp capping in these cases. However, if the size of the exposure is large, like this, if the size of the exposure is large, it is not a pinpoint exposure, so we have to go for RCT in those cases. Also, if the pulp is non-vital, we have to go for RCT. So when is RCT done? For a non-vital pulp and large exposure. And when is DPC done? For a vital pulp in cases of mechanical exposure and or pinpoint exposure. There are some more criteria which help us to decide if we have to do DPC or RCT. For example, duration of hemorrhage and the duration between the pulpal exposure and treatment. So basically, DPC and IPC come under vital pulp therapy, which in itself is a different topic. So focusing on RCT in this video, we have to keep in mind for cases of non-vital pulp and large exposure, the tooth will go for RCT. Coming on to the signs and symptoms of various pulpal and periapical diseases, I'll be discussing these in brief so that you have an idea. In reversible pulpitis, the pain occurs in response to stimuli, and the stimuli can be cold, sweet, and sour food. Okay, so the nature of the pain is sharp and it is of short duration. Since it is a reversible pulpitis, therefore the pain will relieve on removal of the stimulus. As soon as we remove the stimulus, the pain will go away. So then comes the irreversible pulpitis. In irreversible pulpitis, the pain is spontaneous and continuous. Continuous matlab even if the and lingering, okay? So even after the stimulus is removed, the pain will continue to occur and can be nocturnal. The pain can occur during night time. Also, in cases of irreversible pulpitis, the pain can be referred towards the ear region, temple, or sinus region. So we know in thermal test there is heat test and cold test. When the cold test is applied in cases of reversible pulpitis, there will be increased pain. However, when the cold test is applied in cases of irreversible pulpitis, there will be a temporary relief from pain. Okay, so what is the cause for that? In pulp, there are two kinds of fibers, A delta and C fibers. C fibers are located deep therefore are associated with irreversible pulpitis. So C fibers respond to increased intrapulpal pressure. How whenever the intrapulpal pressure increases, C fibers are stimulated and the pain occurs. So intrapulpal pressure can be increased because of vasodilatation. We know because of cold there occurs vasoconstriction. So vasoconstriction will decrease the intrapulpal pressure, therefore the temporary relief from pain. Hence the cold test can be used to differentiate clinically between the reversible and irreversible. Then comes the pulp polyp. It can be seen as a pinkish red globule protruding from the pulp chamber and filling into the cavity. It is seen in young and resistant pulps. So, what is the treatment of pulp polyp? If the tooth can be restored, that is, if there is no furcation involvement, मतलब के pulp polyp तो है but furcation is intact, then RCT can be done. But if it is involving the furcation also, then we have to go for extraction. Coming on to irreversible pulpitis, since it is irreversible pulpitis, that is, the pulp is incapable of healing, therefore RCT is mandatory. Then coming on to reversible pulpitis, either we can go for conventional cavity or we can go for IPC. It will depend upon the depth of the lesion. Coming on to the periapical diseases, I'll be just giving you a brief about the various signs and symptoms which you can come across if a tooth is having a periapical disease. So, in cases of acute periapical abscess matlab formation of pus. In case of acute periapical abscess, the TOP will be positive. Radiographically, if you see a case of acute periapical abscess, the lamina dura, this is the lamina dura, it will be broken and there will be the widening of pedial space at the apical region. And in cases of chronic periapical abscess, the lamina dura will be broken, pedial space will be widened, along with there will be an ill-defined radiodecency at the apical region. So, this is acute periapical abscess and this is the chronic periapical abscess. In cases of chronic periapical abscess, there you may find a sinus through which the pus is draining out. Okay, since the pus is draining out, therefore chronic periapical abscess cases there will be dull pain or no pain, while as in acute periapical abscess cases there will be a severe pain and TOP will be positive. TOP comes out to be positive only when the infection spreads to the periapical region, because PDL, which is present in the periapical region, contains proprioceptive receptors which are lacking in the pulp. So, if the infection is present only in the pulp, the TOP can never be positive. It is positive only when the infection spreads to the periapical region. Other signs and symptoms which we may come across if in a patient who is having a periapical disease are swelling or tooth mobility, etc. So, this was just a brief about the signs and symptoms of periapical and pulpal diseases. In the next video, I'll be discussing about the number and location of root canals present in different teeth along with the steps of RCT.